Good afternoon, everyone. On behalf of University Hospitals, our entire family, thank you for joining us for today's webinar on hip and knee pain in adults, its causes, non-surgical and surgical options for treatment. My name is Rich Riley. I'm a member of University Hospitals Marketing and Communications team, and I'll be your moderator for today's event. A few housekeeping notes before we begin. In this platform, all attendees are muted. While you won't be able to ask questions through your microphone, please note the Q&A function at the bottom of your screen. If you have a question that is not addressed during the presentation, please submit your question through the Q&A feature, and our presenter will address questions at the end of his presentation. Also, today's webinar is being recorded and will be available for viewing on demand in the near future. It will be posted on our website, and as an attendee of today's session, you'll receive an email with that link. It is now my pleasure to introduce our presenter for today. Dr. William Stanfield has been in practice at the Center for Orthopedics since 1997. University Hospitals, the Center for Orthopedics' main location is at UH Sheffield Health Center, which is conveniently located off Route 2 and 254 in Sheffield. For those of you familiar with the large Mike Bass Ford dealership, they're right across the street. They also have office locations in Amherst, Oberlin, and Westlake. Dr. Stanfield is board-certified orthopedic surgeon specializing in joint replacement, sports medicine, arthroscopy, and fracture care. Raised in Vermillion and a graduate of Vermillion High School, he received his Doctor of Medicine degree from the Ohio State University College of Medicine and completed his orthopedic surgery residency and general surgery internship at St. Luke's Medical Center in Cleveland, Ohio. Throughout his career, Dr. Stanfield has continued to focus on new innovations in joint replacement surgery, including the use of Mako robotic arm-assisted technology for hip and knee replacement. As Dr. Stanfield states, active people, like many of the patients I treat, need joint replacement in order to return to the activities they love. It's a good feeling when my patients tell me they're back to bike riding, exercising, and playing with their grandkids after having joint replacement. My goal is to get my patients back to their normal activities as painlessly as possible. Dr. Stanfield's leadership accomplishments include founder of the Amherst Hospital Joint Center, current director of the Center for Bone and Joint Reconstruction Department, and chairman of the Department of Orthopedic Surgery at UH Elyria Medical Center. He is also a member of the prestigious American Association of Hip and Knee Surgeons, the Ohio State Medical Association, the Cleveland Orthopedic Society, and Lorain County Medical Society. Ladies and gentlemen, I'm proud to present to you Dr. William Stanfield.
Thank you, Rich. I appreciate that. That was quite an introduction. Very good. Thank you. Today I'm going to talk about hip and knee pain and hip and knee arthritis and some of the surgical procedures that we do in order to treat arthritis. And so I'm going to move through some slides as we do that. But as Rich said, there will be plenty of time at the end for questions. And so submit the questions and I'll be happy to answer as many of those as I possibly can based on our time constraints. Just a quick disclosure statement. I don't have any disclosures. I'm not paid by any implant company to use this particular implant or a particular technique. All of my surgical decisions are based on my preference. I did have some help with this talk by Dr. Popa, my partner, who's also a joint replacement surgeon. And so I wanted to give him credit with helping me to put these slides together. Rich covered a lot of this, so I'm not going to go through my background other than to say that I'm a local boy. I've been in Ohio my entire life. Grew up in Vermillion, went to college in Berea at BW, went to medical school in Columbus at Ohio State, did my residency in Cleveland at St. Luke's. And when I finished my residency in '97, I came straight here back home to Elyria and joined the Center for Orthopedics, and we are part of the University Hospital Medical System. Joint replacement has been my specialty. Primarily I do hip and knee replacements. We do cover multiple high schools as their team doctors, as well as some of the professional teams, the Lake Erie Crushers, the baseball team that's local, as well as the Cleveland Gladiators, the football team. Just an outline of what we're going to discuss today. We're going to talk about hip and knee joint pain particularly, some of the methods that we use to treat them, as well as the diagnosis, and a little bit about robots at the end of the procedure, or excuse me, at the end of the conversation. When we talk about joint pain, there's three typical types of arthritis that can cause joint pain. There's osteoarthritis, inflammatory arthritis, and post-traumatic arthritis. And I'm going to talk a little bit about each of those as well. Osteoarthritis, which we sometimes refer to as degenerative arthritis, is essentially just a wearing out of joints. As that cartilage, that shiny Teflon coating at the end of the joint wears out and becomes rough and irregular, those bones start to rub together, and that's what causes the pain and stiffness associated with arthritis. Osteoarthritis in 2005, so this data is a little bit dated, but it was estimated that 27 million people suffered from osteoarthritis, and it was predicted by 2030 that over 50% of Americans 65 or older would suffer from osteoarthritis. It is the most common cause of disability and missed work days. Inflammatory arthritis is a little bit different. It's a process where the body actually attacks itself. There's an immune response that occurs, and this is what causes the destruction in the joints. The most common examples of that would be rheumatoid arthritis and lupus. They are inflammatory types of arthritis. Over 1.5 million people in the United States have rheumatoid arthritis. It occurs most commonly between the ages of 30 and 60, and it's 3 times more common in women than men. When men are affected by rheumatoid arthritis, it's usually later in life in an older age group. Post-traumatic arthritis, as it sounds, is after an injury to a joint, such as this knee injury. It develops damage to the joint or the cartilage or the ligaments, and that damage over time leads to arthritis or a wearing out of the joint. Some common questions that we get in the office from patients who suffer from joint pain. I have pain in my groin. Is that arthritis? What if it's in my back? How do I know the difference? Is it normal if I don't feel the pain all the time? Why does my back hurt and then it radiates down into my knee? There are so many different conditions that can lead to joint pain, and I wanted to talk a little bit about that as well. Degenerative joint pain can be constant or it can come and go. Many patients feel after they sit for a prolonged period of time, when they first get up, they have a lot of joint pain, then things feel a little bit better as they get moving. But if they're on their feet or on those weight-bearing joints for too long, that's when they can become more painful. As I said, it can occur with movement or after a period of rest, and it can affect one single joint or it can affect multiple joints throughout the body. This is just a picture on the right and a diagram on the left of a hip joint. And so here on the left, you can see the hip joint, you can see the ball and socket. The blue shaded area is to represent that cartilage coating, and that's smooth and it glides and it doesn't feel pain. On the x-ray, all we can see are bones. And so we can see the outline of the bone, but we know this space in between, which is labeled as the normal joint space, that's what's filled with cartilage. And we'll see later with some of the other x-rays when that cartilage is worn out, what that x-ray would look like. Here's a knee joint. Similarly, on the left, you can see the diagram of the knee joint showing the ligaments and the cartilage, the blue again representing the cartilage. And then on the right, the x-ray of the knee joint, which shows that space between the thigh bone and the shin bone, and that space is filled with cartilage. It's just that cartilage doesn't show on a normal x-ray. So when a patient comes to my office and tells me that their hip hurts, we need to go through a specific series of questions to try and identify what is causing that hip pain. This list is not here for me to read all of these titles, just to get a grasp of the multiple things that can cause hip pain and the things that we need to consider when a patient comes in complaining of hip pain. You can see it's pretty extensive. Most commonly, however, there's 3 typical conditions which lead a patient to come to their orthopedic surgeon for hip pain. The first is back pain or lumbar radiculopathy or sciatica. A lot of times pain from the low back can radiate down into the hip and down the leg, and that can be a cause for hip pain. Another condition that we'll talk about is bursitis or tendonitis in the hip, which can also be a common cause for hip pain. And then lastly, hip osteoarthritis or joint wearing out. That type of hip pain is what my area of expertise is in. So when a patient comes in, when we're trying to separate these things, what goes through my mind is it's probably coming from your back. If you feel it in the posterior or the back side of the hip, if it radiates down the leg, especially if it goes down all the way to the foot or below the knee, if it's caused by specific activity such as coughing or sneezing, that can be a sign of a disc problem in your back that's irritating the nerves coming down your leg. And if it's associated with numbness or tingling, then it's probably referred pain coming from your back. It's probably coming from the bursa or tendonitis on the hip if you feel it on the side of the hip. If you feel it after you've been seated for a long time or getting up out of a car, or especially if you lay on that side at night and you have pain, that's a sign that it's a bursitis problem or tendonitis in the hip. Pain that occurs when you go up and down stairs also typically is related to the bursa. This picture that just popped up here on the bottom left shows that hip joint, but this picture actually shows the bursa where it occurs, and it's right here on the side of the hip, on that bony part of your hip that tends to be tender when you lay on that side. And then finally, it's probably coming from your hip. If you feel it in the groin, a common sign that we refer to is what we call the C sign, when a patient, as in the picture, shapes their hand in the shape of a letter C and then points it around the hip joint, because the hip joint is deep in the groin area. And so that's where the localized pain from hip osteoarthritis typically occurs. Pain that occurs in the morning after you've been sleeping and when you first start moving tends to be stiff. And then pain that becomes worse with walking is typical for hip osteoarthritis. The joint tends to become stiffened or has decreased range of motion due to the arthritis, the lack of cartilage, and the bone spurs that form. So limited mobility is very common with hip arthritis and not so much with tendonitis or bursitis or back problems. Here's that picture of the hip joint again, showing the cartilage in the hip joint in a normal hip. And then on the right is when that cartilage wears out, the ball part becomes roughened and has these bone spurs. The socket also becomes roughened and irregular, and there's no more shiny Teflon smooth coating. There's exposed bone, and exposed bone has nerve fibers, and that's where the pain from arthritis comes from. Jumping to the knee joint, similarly, there's lots of different things that can cause pain in the knee. Osteoarthritis of the knee is a common one, but it also can be related to tendonitis or synovitis or a torn cartilage or nerve pain coming from your back, or even hip osteoarthritis sometimes radiates down to the knee joint. So there's multiple conditions that can cause knee pain that we need to work our way through when a patient comes in for evaluation of knee pain. It's important to differentiate what is causing the pain, because common sense rules, but a knee replacement isn't going to solve a problem if it's coming from hip arthritis. And similarly, a hip replacement won't cure nerve pain that's coming from the back. And so it's very important to pinpoint where that condition is coming from so that we can determine the appropriate treatment. This decision in making this diagnosis is primarily based on a history of the pain symptoms, how long they've been present, and what symptoms they are, a physical examination, and then x-rays. Sometimes we'll do injections. Here on the left is a hip joint that's being injected with some cortisone, and on the right is also a hip joint being injected, but this is using ultrasound guidance. Here's an x-ray of a normal knee on the left, where you can see the thigh bone above and the shin bone below and that cartilage space in between. That's a well-preserved joint without signs of arthritis. And then on the right, on the opposite extreme, is severe knee arthritis, where the bones aren't really straight anymore. This is some bow-legged type deformity. You can see bone rubbing on bone here on the inside of the knee, a little bit of cartilage space on the outside, and then bone spurs throughout. This is severe knee arthritis. Here's a hip x-ray. This is the same x-ray I showed earlier, where you can see the ball and the socket in that space in between. And then on the right is a hip with severe hip arthritis, where you can see the ball and the socket, but there's no space in between, and the bone appears more white, and that's a sign of stress and extra calcification in the bone due to the stress in the bone from the arthritis. But there's no cartilage space, and this is bone on bone in a hip joint. So moving on to treatment for hip and knee arthritis, One of the most important things is the stress. These are weight-bearing joints, and so the stress across these bones is amplified by increased weight. And so some literature based on weight loss has shown that for every pound of weight that you lose, you take 4 pounds of pressure off of your knees. And so weight loss is an important treatment for arthritic changes in both the knee and the hip. So alternating your diet and incorporating low impact exercises can be very helpful. A study was done in 2010. I have a lot of patients who come in who say, well, I can't lose the weight because I can't exercise because I've got really bad arthritis in my knee. Well, some researchers looked at that, and what they found was pretty surprising, that patients who were overweight, who had a knee replacement, after the knee replacement, 16% of those patients lost weight, but 23% of those patients actually gained weight after their knee replacement. And so it's much more beneficial to lose the weight before the procedure than to hope that you're going to lose the weight afterwards. Additionally, that weight loss before the procedure also decreases the risks associated with knee and hip replacement, because being overweight increases your risk for blood loss, infection, and blood clot, which are all potentially serious complications of joint replacement. Walking aids can be very helpful with the symptoms of arthritis. Using a walker or a cane or crutches can definitely take some of the weight off of that arthritic joint and decrease the pain associated with that. Heat and cold therapy also can provide symptomatic relief. Cold therapy can definitely help with swelling and pain at the end of the day, whereas heat tends to help with stiffness and can help loosen up a joint that's stiff from arthritis. And then we move on to medications. Oral medications are medications that are taken by the mouth. The over-the-counter treatments are Tylenol and other what we call non-steroidal anti-inflammatory medications. That's Aleve and ibuprofen and Motrin. These are anti-inflammatory. They help with swelling and inflammation, but also help with pain. Tylenol is just a pain reliever that's over the counter. There are other supplements that are available over the counter, including glucosamine and chondroitin. They have been shown to decrease the symptoms of arthritis, but they don't reverse the changes of arthritis. And so once that joint is worn out, these supplements don't rebuild cartilage, but they do help with the pain associated with arthritis. In order to notice improvement, it's important to stay with them for a period of 6 to 8 weeks. There's no guarantee with these treatments, but they can be helpful. There's other herbal and dietary supplements that are available, but the jury's still out on how much they can help. Physical therapy, especially in the earlier stages of mild to moderate arthritis, can be very helpful to help with the flexibility of joints and building the strength around the joint to take pressure off of those joints. Activity modification can be very important. If a patient has knee or hip arthritis, it's not a great idea to be exercising by running on a treadmill, because this is a weight-bearing joint, and that repetitive impact is just not a good idea. A much better idea is swimming, where gravity is eliminated and there's no stress on these weight-bearing joints, or even an elliptical machine where your feet are planted, or an exercise bike. Those can be very helpful, but also not providing repetitive stress on those weight-bearing joints. Injections are a standard treatment for arthritis of the hip and knee. The most common is a steroid injection. That can be both diagnostic and therapeutic. And what I mean by that is if we're not 100% sure if pain in the knee is coming from the knee arthritis, then a cortisone injection can be very helpful, because if it relieves the symptoms, then we know for sure that that's where the problem is coming from and that it's not a hip or a back problem. And additionally, it's therapeutic in that it relieves the symptoms, and then it's just a matter of seeing how long that symptom relief lasts. Steroid injections can only be done 2 or 3 times a year, and we try to wait at least 3 months between injections. So it's important to spread those out, because there can be side effects to repetitive steroid injections. Visco supplementation or gel injections are these synthetic joint lubricants that are now available. They're only FDA approved for use in the knee joint, but they provide a cushion in the knee joint, because one of the problems with arthritis is that normal cushioning fluid no longer is doing the job that it's supposed to do. This visco supplementation or this gel injection provides that cushion in the knee joint, and they've been shown to be effective in the treatment of arthritis. Stem cell injections or other biologics, I just wanted to bring those into the talk because they come up a lot at these conversations. Some of the claims with stem cells I would be very leery of. The literature is all over the board on stem cell injections. What I can tell you they don't do is reverse the changes. Once the cartilage is worn out and you have bone spurs and you have bone rubbing on bone like this picture in the middle here, it is not going to turn into this picture on the right. The bone spurs are not going to go away and that cartilage is not going to rebuild. And so when they look at the efficacy or the benefits of stem cell injections, they can help with the symptoms, but I would just say use caution because a lot of the places doing stem cell injections are making claims that really are not supported by the literature. Additionally, stem cell injections are considered experimental by most insurance companies, and so usually it's an out-of-pocket expense and they can be quite expensive. And moving on to surgery, the decision for surgery clearly is a very big decision, and patients are often asking me, when is it time to get my knee replacement or my hip replacement? And so my answer is always the same: you'll know when you're ready, and you know when you're ready when your activity is significantly less because of that joint pain, when it's keeping you from doing the things that you want to do. You're having difficulty going up or down stairs, and you have difficulty sleeping at night. These are all signs that your arthritis pain is not being controlled by standard treatments and that you may be ready to consider joint replacement. When we talk about joint replacement, this is a picture of what we're talking about. This is that hip joint again, but after a hip replacement. So we can see a new socket with a plastic spacer in between with a new ball, and then the stem that goes down inside the thigh bone, and that's a full hip replacement. Over 300,000 hip replacements are performed in the United States every single year. This is another picture of that hip replacement. Again, you can see the pelvic bone above, the thigh bone down below, and then the hip replacement here in the middle. I have a brief video of a hip replacement that I wanted to just run through. And so this is a patient laying, their backside is over here, their front is over here, and then we can see as we move deeper towards the hip joint, you can see the muscles, then we work our way down into the hip joint, and here you can see that arthritic hip joint with the spurs, with the worn out hip. We remove that worn out ball, we put a new socket up into the pelvic bone with this plastic spacer or liner, which is the cushion in between. The stem goes down inside the thigh bone with a new metal or ceramic ball. And then we put the hip back together and it bends and straightens like a normal hip, but there's no more bone rubbing on bone, so no more pain from that hip arthritis. Oops. Moving on to knee replacement. Knee replacement is a little bit different than hip replacement because when we catch a knee in its earlier stages, there are other options besides the full knee replacement. And one of those is a partial knee. This is a front view of the knee as it moves through early to late stage arthritis. And in early stages where the pink or red is to demonstrate the arthritis, if it only involves a small portion of the knee, then these patients can be a candidate for a partial replacement where we only replace that worn out area of the knee. Whereas on the other extreme, when the arthritis is kind of all throughout the knee, those patients aren't going to do well with a partial knee replacement, and a full knee replacement is a much better option. Here's that partial knee replacement. Here's the thigh bone, the shin bone, and we can see the normal ligaments that are left in position. But here's the metal piece on the end of the thigh bone, the metal piece on the top of the shin bone, and then that plastic spacer in between. This other side of the knee, which did not have the arthritis, is left as is. Whereas on the other side of the slide is the full knee replacement with the metal piece covering the entire end of the thigh bone, the metal piece on the shin bone, and that plastic spacer in between. So this is the difference between a partial knee replacement and the full knee replacement. Over 700,000 knee replacements in 2017. So it's an extremely common knee procedure and an extremely successful procedure as well. I have another quick video of a knee replacement. And so again, here's that picture of the knee replacement. We can see the knee joint here as we work our way down to the bone. Here's the thigh bone and then the shin bone below with that worn out knee. We make a series of cuts on the end of the thigh bone and on the top of the shin bone. It's a metal piece that goes as a cover for both with this plastic spacer in between. So again, it bends and straightens like the normal joint, but there's no more bone rubbing on bone, so no more pain from the arthritis. Lots of patients ask me, can I get arthritis after a knee replacement? And you can see the answer is no, because there's no more joint, it's metal and plastic. And so you can't get arthritis after a knee or a hip replacement. Some other common questions about joint replacement. Can I have an allergic reaction to the implant? The implants are metal primarily, and there are some patients who do have a true allergy to metal or a metal sensitivity. There are options for treatment where we have ceramic implants or other types of alloys that can be used in patients who have severe allergy, but there is a small risk for an allergic reaction with an implant. Will those implants set off metal detectors? Yes, as I said, they're metal. And so if a metal detector is functional, then it most likely is going to go off when you have a knee or hip replacement. Is the implant heavy? Most implants are not as heavy as you might think. The average weight is about 1 pound between the components, and so not significantly heavier than what we're taking out at the time of the surgery. Now I want to talk a little bit about some of the newer technology with joint replacements, specifically the robotic arm assisted procedure or the Mako procedure. This is a picture of the robot that we use to assist us with that knee or hip replacement when we're doing the Mako procedure. This is a quick picture of, normally I would ask the crowd, what are these images of? But with this Zoom technology, I'm still trying to figure that out. So I'll tell you the answers as I ask them. But this is a CAT scan of a knee, and this is a CAT scan of a hip. And the CAT scan is a specific X-ray test that's three-dimensional, and it takes pictures in slices. And so almost like a meat slicer, we can see images of the knee and hip replacement. And then what we have with Mako technology is the ability to do a 3D reconstruction of that worn out joint. And so the CAT scans are performed of a knee or of a hip, and then we get a 3D reconstruction of that joint so we can determine the exact size and location where we want to put that implant specific to each patient's individual anatomy. And that's the benefit of this Mako technology. So here's that CAT scan. Up on the top right is a knee. We can see a front view of that 3D reconstruction of the knee, a side view over here, and then a view of the knee replacement. The green represents the knee replacement. This is a partial knee replacement below. So the metal piece on the thigh bone here, we can determine exactly what size we want to put in and exactly where we want to locate these implants that are specific to each patient's individual anatomy. Here again is a hip replacement. This is the CAT scan here on the left. And then on the right is that 3D reconstruction of the pelvis. And then we can implant, quote unquote, the hip replacement here. So we can determine what the leg length is going to be after the procedure, where we're going to position those implants so that we know before we even get to the operating room, how we're going to perform that procedure and what it's going to look like when we're done. And then at the time of the procedure, here's a hip replacement. As we're doing the socket piece, we get visual and tactile feedback exactly how much and what position we're in so that we know we're exactly where we want to be. It's almost like a high-tech GPS system that guides us throughout the procedure. Here we are doing a partial knee replacement, and then this is the full knee replacement here on the right. After surgery, here's a hip replacement that's been done with that Mako technology. Here's the partial knee replacement, and then the full knee replacement on the far right here. After surgery, most of our patients are discharged within 24 hours. Most patients get up with physical therapy the day of surgery and participate in their rehab. Typically, it's 2 to 3 weeks with a walker, and then another 2 to 3 weeks with a cane. By 6 weeks, most patients are getting around pretty well, and about 3 months to heal completely from knee or hip replacement. Realistic activities after knee or hip replacement, walking, biking, swimming, other low impact type activities like golf are all very beneficial after joint replacement, and we encourage patients to participate. Another common question with this new technology, how new is it? How long has it been available? And actually, we started doing Mako technology in Elyria in 2007. It first became available in 2006. And so it's almost 15 years now that we've been doing Mako procedures, and over 200,000 knee and hip replacements are performed worldwide. Another question is, does the robot actually perform the surgery? And the answer is no. As I said, it's more like a GPS system that tells us where we need to be and helps guide us to keep us from straying from our planned target, but the surgeon is actually performing the procedure. Some of the benefits that we're expecting with Mako robotic assisted: shorter hospital stays, lower postoperative pain, less need for therapy, improved implant alignment. We know going into the procedure where it's going to be when we're done. Traditional instrumentation for hip and knee replacement is less reliable. It's a very, very good operation, however it's done, but the Mako just takes it to another level so that we know exactly where things are going to be before they're done. So, as Rich said, Center for Orthopedics, our main office is the big building in Sheffield. We have multiple physicians who are able to help all sorts of different conditions, not just knee and hip replacement. I did want to save time at the end today so we could take some questions. I think Rich is going to help me to answer questions, but there's a number here to call if you have additional questions or concerns or want to set up an appointment.
Absolutely. So we do have some questions that were sent in. First question is, will a partially torn meniscus and a PCL tear heal by themselves with physical therapy, and any problems with knee later in life?
Okay, a torn meniscus, the meniscus is like the rubber cushion between the bones in the knee. And like rubber, it doesn't have an ability to heal itself. When it's torn completely, it's not gonna heal. It's like a rock in your shoe that gets pinched and caught in there. A partially torn meniscus can mean a lot of different things, and so it's hard for me to comment on that. But if it's torn completely, then it's not likely to heal with physical therapy. A PCL is the posterior cruciate ligament. It's one of the main ligaments in the back of the knee. And that is a ligament that, whether it's partially torn or completely torn, oftentimes can be treated with just rehab and strengthening the muscles around the knee so that it doesn't require additional surgery and doesn't have additional risk for damage down the road. A torn cartilage or a torn meniscus, if it's a complete tear and it goes untreated, does have some risk of progressing and becoming more severe and potentially leading to more arthritis down the road.
Great. So we have a participant who had knee replacement that was done in 2003. They want to know how long they should expect that replacement to last.
That's a great question, and one that I meant to address during my talk. I'm glad that you brought that up. Knee and hip replacement, the traditional teaching has been that they'll last 15 to 20 years. With some of the newer technologies and the ceramics and the plastics, we think they're going to last much longer than that, more on the 20-year range. But I have patients that come to my office now that had their knee or hip replaced 20, 25 years ago, and they're still doing very well without signs of wear or loosening. And so there is no warranty date that says that after 20 years you have to have it redone. Many of these joint replacements last well beyond that 20-year range.
Great. That is a question a lot of people have. So in the area of gel injections, are you able to get gel injections in the hip for hip pain?
Yeah, that's a good question. Gel injections, as I said in the talk, are only FDA approved for use in the knee. And the reason I say it like that is because as a physician and as a patient, you do have a right to use things as long as you're informed that are, quote, off-label or not as intended by the FDA. And so they can be used in the hip or even in the shoulder, but we definitely don't recommend that. If a patient is extremely sick and not a candidate for surgery, sometimes we'll do off-label use of these sorts of things, but it's not the standard of care for sure.
Okay, thank you. Another question. If someone has arthritis in the knee and has a partial knee replacement, what's the likelihood of having new and or additional arthritis in the unaltered portion of the knee? How do you address this? Is there anything that can be done to prevent it?
Yeah, that's something that we see a lot. A partial knee replacement, as we talked about in the talk, it only addresses a part of the knee. And so if there is arthritic changes, or if there are arthritic changes in the other areas of the knee, that patient is probably better served with the full knee replacement. That being said, in younger patients who we know are going to have problems down the road, sometimes we'll do the partial knee replacement knowing that down the road their arthritis is probably going to progress and they may need to be converted to the full knee replacement. And so there are occasions when we'll take the partial knee and convert it to the full knee replacement because of the progression of arthritis in other areas of that joint. When that happens, we don't have a lot of options. Once the partial knee replacement is in the joint, there's metal and plastic in there, and there's risk for infections. And so lubricants and cortisone shots aren't recommended after there's been a replacement. And so it can be treated with therapy and medication, but if those treatments aren't working, then the best way to address additional arthritis after a partial replacement is to convert that to the full knee replacement.
Great. Can you please discuss the pros and cons of having hip surgery with an incision in the front or the side or the rear of the hip?
That, again, another great question. And there's a lot of information, I'll say, on the internet and going around about anterior approach and posterior approach. And I have multiple patients come in asking me what approach I'm going to use. And it is my opinion that the most important thing when you're deciding on hip replacement is to have a surgeon that you trust who's competent and who's done multiple hip surgeries. And whatever approach they do, I'm sure is the one that they do best. There is no one best approach. They've done multiple studies comparing anterior approach to posterior approach to lateral approach. And you can find studies that say one's better, and you can find studies that say that's the worst. And so there is no best approach. It's whatever your surgeon is most comfortable with and that they do most routinely, that's the approach that's best for you.
So we know that you do hip and knee replacement. Will you or any of your colleagues be doing ankle replacements?
Yeah, at this current time, none of our surgeons in our office do ankle replacements. Ankle replacement is a operation that's still in evolution. It has some very good results in patients who aren't super active, but in extremely active patients, it's an operation that's difficult to recover from, and they don't last nearly as long as hip and knee replacements. We are looking and interested in the opportunity to be able to do that. University Hospitals does have surgeons who can do this, but within our group here in Elyria, we don't have that opportunity.
Great, thank you. Do you reattach ligaments in the surgery to help the hip or knee joint move after replacement?
I'll take each of those separately. In a knee replacement, we don't detach ligaments, so we don't have to reattach them. I hope that makes sense. With hip replacement, similarly, we do what we call I do a minimally invasive procedure where we only detach or separate what we need to get into the hip joint to do a safe operation. Flipping back to my training, which we started this conversation with, I remember clearly the physicians who were great doctors who taught me, but they were always preaching to do a bigger incision so that you could see, so that you don't have to struggle with a procedure, and skin heals side to side, so there's no reason not to make a bigger incision. It'll heal just fine, just like a small incision. Well, what we've learned over the years is that a minimally invasive approach where there's less tissue and muscle damage, those tend to heal much more quickly, and those patients can be active much sooner after the procedure. And so it's much more important to preserve those soft tissues and not detach anything that you don't need to detach in order to do the joint replacement.
Great. Let's see here. We have several more questions. Would you recommend trying the visco supplementation before going in for a total knee replacement? Is there a benefit to trying that first?
Each individual patient has to make those decisions themselves. Some patients on their first visit, when they're diagnosed with severe knee arthritis, we go through those options, and some patients are of the mindset that hey, if I'm going to need this knee replacement anyways, why would I put that off? I'd rather just get it done and get on with my life. Whereas other patients are of the mindset that I'll try anything before I have to do joint replacement. And so that's an individual decision, but you're certainly not burning any bridges by trying the visco supplementation. The results of visco supplementation are mixed. About 75% of the people notice some improvement, but that some improvement is sometimes a little, sometimes a lot. I have some patients who come back a year or two later and say, hey, can I try those gel shots again? They worked great. I have others who come back a month or two later and say that did nothing for me. I'm ready. Let's get this thing fixed.
Great. Another question. If a person has pain in the back of the knee, is that associated with the joint?
Pain that occurs in the back of the knee can be caused by a lot of different things, but specifically when it relates to knee arthritis, what the most common cause for pain in the back of the knee would be what we call a Baker cyst. And a Baker cyst, it's not a tumor or cancer or anything like that. Essentially, it's swelling in the knee. When the knee is irritated for any reason, its response is to make more fluid. And when that fluid collects in the back of the knee, it can become encapsulated, and we call that a Baker cyst. So typically with severe knee arthritis and pain in the back of the knee, it's usually related to the pressure that occurs from a Baker cyst or that fluid collection behind the knee.
How is the decision made to use ceramic versus metal knee replacement? Is being allergic to metal the only basis for using ceramic?
Yeah, ceramic clearly has its benefit in the metal allergy patient because obviously it doesn't have metal, but there's also a trade-off. Ceramic is more brittle. And so the knee especially is subject to a lot of stress. And so there's the risks associated with using ceramic. And the standard knee replacement is a metal knee replacement with a plastic spacer in between because we know that that's going to hold up to the test of time. The ceramic knee replacements also have benefit. Ceramic is super smooth, so there's less wear, and ceramic certainly can be used in metal allergy patients. But ceramic also has some downside as far as expense. It's a significantly more expensive joint replacement, and its risk for the brittleness or the stability of that ceramic material.
So we have several questions that are answering what you probably hear a lot. When is it time to see you? For example, one person noted that they're starting to feel discomfort in their joints when they're going down the stairs. Anything, any direction you can provide?
Yeah, I think typically, we're here for anyone. If you're just starting to have symptoms and you want to find out, is it related to arthritis? We're happy to take care and figure that out and treat that from the start. If you've been dealing with arthritis for many years and you have arthritis, we're happy to take care of those patients as well. An orthopedic surgeon is not just a surgeon. We still treat arthritis from start to finish. I'm not telling you not to go to your family doctor or your medical doctor, but I am telling you that we do more than just surgery. In fact, a majority of my practice is non-surgical, where we take care of patients with arthritis.
Great. Another question. An individual that had knee replacement but still has his original kneecap. He wants to know, will this go bad? Will it have to be replaced? The replacement was 3 years ago.
Okay. The kneecap is addressed at the time of knee replacement. Most times, most surgeons are putting a plastic button behind the kneecap so that the kneecap isn't rubbing on the metal implant. A majority of the patient's own kneecap is left in position, and then a button is placed behind it. Occasionally, if there are no arthritic changes in the kneecap itself, we will leave the entire kneecap without the button. And those have been shown to do just as well as traditional knee replacement. And so that doesn't mean you're going to need to have that replaced down the road. It doesn't increase your risk for any other complications or problems. That decision is made at the time of surgery based on the amount of arthritis behind the kneecap.
Great. Another question. My knee locks up and is very painful when I bend it. Is there any way I can do physical therapy to make that stop or help it not hurt so much?
Um, a knee that locks up, in my mind, is a knee that you try to move and then it gets stuck and then it gets unstuck. And that's what I think of when I hear of locking. And the most common causes for locking are these mechanical type symptoms would be a loose piece floating in the knee that's getting caught between the bones, or a torn cartilage or a torn meniscus. And most times those won't go away on their own. A knee that gets stiff, on the other hand, is a knee that you try to bend and it's just hard to bend, but then it loosens up. And so stiffness definitely can show improvement with physical therapy and rehab, whereas locking, or that mechanical symptom, is less likely to improve with physical therapy and rehab.
Great. If you've had total knee replacement 3 years ago and then a revision 2 years ago, and it does not seem right, what would my next option be?
Yeah, that clearly is a complicated question that I could spend another hour talking about. But if you had 2 operations within 2 years and it's still not feeling right, that can be one of any number of causes. So it'd be hard to get into that. And it depends on the cause for the second operation to help determine what the cause for persistent pain would be. So I'm not sure I can get into that. As I said, knee replacement is an extremely reliable, predictable operation, over a 95% success rate. But there are a small percentage of patients who don't have the perfect result with knee or hip replacement. And those certainly can be more complicated, but they're also a great challenge to try to figure out and address those patients and their complications.
Great. I have moderate to severe osteoarthritis in my hips. I've lost 35 pounds and do low impact aerobics every day. Am I still a candidate for hip replacement if I don't take prescribed drugs first?
Yeah, I think that as I said earlier, each individual has to make their own decision. Whether you're a candidate for joint replacement is based on your symptoms and quality of life, number one, the severity of the arthritis, number two, and your risk factors for a surgical procedure. And being significantly overweight can be a risk factor. And so without having all that information, I can't say for sure, but those are the factors that go into determining whether or not a patient's a candidate for joint replacement.
Great. What other pre-requirements are there before you can have a hip replacement, or basically what does a patient have to do before they have surgery?
Well, once the surgeon and the patient have a discussion and make the determination that that patient is a candidate for joint replacement, and the patient makes the decision that they want to go ahead and proceed, there are some risks associated with this procedure. And so the standard treatment would be for us to get a medical risk assessment to send the patient back to their family doctor to make sure that their other medical conditions are as optimized as possible, because this is not an emergent surgery, it's an elective procedure. And so we have time to, quote, tune that patient up. And so we would send them to their family doc explaining that they're contemplating joint replacement, and have them get tuned up from a medical standpoint as far as their blood pressure and their blood sugars and their diabetes, and make sure that they're in good shape. And if they have a cardiologist, even a workup from the cardiologist to predetermine their risk factors associated with this major surgery. And then there's pre-admission testing with blood work and EKG and that sort of thing. And so there's an extensive workup that goes in once that decision is made to proceed with joint replacement surgery. Great.
Another question. At times it feels like my hip is just going to come out of the socket. Will that actually happen?
The hip joint is a ball and socket, and the ball part is very well covered by the socket. And so a hip that hasn't had surgery or hasn't been replaced, the risks for hip dislocation are extremely rare. It almost never would happen. It has happened to some professional athletes. Some people who follow sports certainly are aware of those incidents, but a hip that hasn't been replaced without severe trauma is not likely to, quote, pop out of the socket.
Great. Another question. So you've talked about the Mako robotic arm assisted technology for hip and knee replacement, and we have a participant asking if there is anyone on the east side who utilizes the Mako technology for replacement at UH.
Yeah, I do not have the answer to that. I know that the Mako technology is being used throughout Cuyahoga County on both the east and west side with multiple providers, but I'm not 100% sure which ones within the UH system, particularly on the east side. I don't know what systems they use out on that side of town.
So on the east side, there are no providers at this time, as far as I know, that are utilizing Mako. But again, Dr. Stanfield and two of his colleagues on the west side at Elyria Medical Center utilize the technology. And if you're interested in getting in touch with him, we'll provide a number at the end of this presentation. And most importantly, you know, after you have your replacement, physical therapy locations are available all throughout Cuyahoga County, close to home. And I know that there are several people that have seen Dr. Stanfield and his colleagues from the east side for the use of the Mako technology. More questions. Is cement used in the total knee replacement?
Good question. Depends on the patient. Some of the younger patients with very good bone quality, we can use an implant that is not cemented or doesn't use glue, whereas older patients whose bone quality might not be as good, we almost always will use cement or glue. Similar with hip replacements, some go in with cement, some go in without, and that's primarily dependent on the quality of the bone at the time of the procedure.
Great. A few more questions. Is it true that there is less chance of dislocating your hip post-surgery with an incision made from the front of the body?
Yeah, an incision made in the front of the body or an anterior incision has been shown to have some reduced risk of dislocation. No doubt about that. Posterior incision or an incision in the back does show some increased risk for dislocation, but there are trade-offs with all different incisions, and so there are other issues with an anterior incision that you don't have with a posterior incision, and so those decisions need to be made as a discussion between the patient and their surgeon.
Okay. Another question, Dr. Stanfield, I have a lot of pain on my left hip and rear while laying on my left side in bed and while I am sitting on a chair. Also, when I sit on a chair for 5 minutes or more, and when I stand up and start walking, I can't walk straight because of the pain on my hip and rear. After a few seconds, I can walk normally. I appreciate some help from you. Thanks.
Yeah, that could be that it's not a hip joint problem at all. It could be the bursitis or tendonitis of the hip that we talked about earlier. And that, with an evaluation, pretty quickly and easily, we could differentiate a hip joint problem from a bursitis problem. And the treatment for bursitis tends to be non-surgical. And usually that involves physical therapy, medication, possibly an injection, but almost never surgery for a bursitis problem.
Great. What are the side effects of steroid injections for the knee?
Steroid injections are pretty safe when it comes to joints, and the risk associated with an injection, because we're putting a foreign material into the joint, there's a small risk for infection. Repeated steroid injections, if they're done more often than recommended, can cause damage to the cartilage and the structures within the joint. And that's why we are limited to 3 to 4 injections per year. But otherwise, it's a very safe procedure. There are some side effects from steroid injections where patients can become flushed or even become sweaty or have some side effects from the injection. They're not an allergy necessarily, but a reaction to the injection. But all in all, cortisone injections are quite safe.
Great. So we have some more questions. We have 2 minutes left, so I'll try to go through these as quickly as possible. What are your thoughts on the concept of a minimally invasive procedure to clean out the knee, where, in theory, the rough areas are smoothed out and trimmed off so the surfaces glide well again?
The benefits of an arthroscopic, or which is what I think we're referring to, or as a minimally invasive procedure, as a treatment for arthritis, have been proven not to be effective. That being said, if a patient has arthritis, but also has damage to the meniscus and loose pieces floating in the knee joint, then there is some benefit to an arthroscopy or a minimally invasive procedure to remove those loose pieces and smooth the torn areas of the cartilage. But as a treatment specifically for arthritis, a minimally invasive or an arthroscopic procedure has been shown to not be the recommended or the standard of care for that.
Great. Two more questions and then we're going to run out of time. What are the indications of a high tibial osteotomy?
Okay, a high tibial osteotomy is a realignment procedure that involves the shin bone just below the knee joint. And some patients are born or develop a severe bow-legged type deformity, and that puts extra pressure on the inside of the knee because the center of gravity is going over the inside of the knee instead of the center of the knee. So that inside of the knee is overstressed, and it's accepting most of that patient's weight. And so a high tibial osteotomy is a realignment procedure to straighten those legs essentially and redistribute the weight over the center of the knee so both sides of the knee are sharing that weight equally. One side's not accepting more of the weight than the other. Those patients are usually the younger patients and before they develop severe arthritic changes in the knee. Once the arthritis gets to be severe, the benefits of a high tibial osteotomy are less. And so it is a procedure that we'll use in severely bowed or malaligned knees in younger patients without severe arthritis.
Great. And I want to end with not a question, but you had a former patient of yours send in a very nice message that I want to share with everyone. Just want to say that you replaced both of my knees 6 years ago, and I do everything. I ride horses, ride my bike with my grandsons, drive a tractor, cut and bale hay, as well as I'm still teaching. Take students on field trips where there's a lot of walking, and I can outwalk most of my younger colleagues. I am now 71 and work like I'm 35 years old thanks to my knee, hip, and shoulder replacements and your great physical therapy department. So tribute to you and your colleagues. So with that, Dr. Stanfield, again, thank you for sharing this very valuable information. To our participants, thank you so much for all of your questions. I'm sorry we couldn't get to all of them. Again, my name is Rich Riley. Feel free to email me any remaining questions that you have, and I will work with you to get those questions answered. For anyone that is interested in seeing Dr. Stanfield, you can call him at 440-435-7640 to make an appointment. Again, 440-435-7640. Just know that in about a week, we'll be emailing you a link to the session that was presented today. It'll also be available on our website if you'd like to review it again. And again, we just want to thank all of you on behalf of the University Hospitals family for joining us today. We'll hope you will join us for upcoming webinars, and just want to wish everyone to have a good day and a great afternoon. Thank you.
Thank you.